to the
This
demo.
is really good.
Aortic regurgitation, a leaking valve, blood which goes back into the left ventricle from the aorta during diastole. Why is it so important to know this entity? Well, because it damages the ventricle. And here we have an example of dilated left ventricle with reduced function caused by aortic regurgitation.
As a matter of fact, this is a young patient who had aortic regurgitation without us knowing, and over the years he developed very poor left ventricle function. In essence, he was a candidate for transplantation in the end. So we have to detect this disease early so that we avoid what happened to this young patient.
And how do we detect AR? Well, again, with color Doppler. Like we do with mitral regurgitation, we have also jet, but here it is originating from the aorta, goes through the aortic valve into the left ventricle. And again, when you use color Doppler, a few advice: make sure the color sector is small. Try to always visualize the origin of the jet, which is more difficult than for mitral regurgitation, and use the image review function. So freeze your image and scroll it back and forth to analyze the jet completely. So which views then are useful to assess AR? Well, the ones which show the aortic valve. So we will use the 5-chamber view, the apical long axis view, so the 3-chamber, the parasternal long axis view, and a short axis view. And now it's your turn. Can you detect AR here? Take a few seconds. Well, we actually see a jet, a small one, really central, coming from calcified aortic valve. And the answer is yes, the jet is small but present. And can you detect AR here? Well, the answer is also yes, because we see the jet going back into the ventricle in the 3 views. And notice this happens during diastole, so when the ventricle is larger.
But aortic regurgitation is not always so easy to see. This is a case where you have to look very closely. Why? Because the jet is rather eccentric. In other words, it's directed towards the anterior leaflet of the mitral valve, and therefore it kind of mixes with the inflow of blood from the left atrium. And both of these jets occur during diastole, so it's sometimes very difficult to see if you have eccentric jets. What about this loop here? Do you see aortic regurgitation here? I'll give you a few seconds. Again, focus on the region where we would expect aortic regurgitation and look closely. No, there is no aortic regurgitation here.
And here, do you see regurgitation? Again, no.
Why are we showing you these examples? Because at least at the beginning of my career, I found it very difficult to detect the aortic regurgitation because it happens during diastole, and diastole sometimes, especially if patients have high heart rate, is rather short, and you have to have a quick eye to detect it. So not always is it easy to detect the aortic regurgitation, and here is some advice.
Yes, exactly. It could be difficult to detect it in case of poor image quality, in case of eccentric jets, as we showed you, in case of tachycardia, where we have a prosthesis, or in case of very small jets.
I mean, very small jets probably wouldn't make a difference because who cares about small jets? They usually don't have any relevance at all, and you find them very frequently, even in normal individuals. But we'll talk about that a little bit later.
In aortic regurgitation, we should ask ourselves 3 questions. Why do we have this jet? How severe it is? And what are the consequences? So when we want to understand why we have the jet, we have to consider that the aortic valve is a 3-dimensional structure. So the jet could come or from the central part of the valve or from the rim. And for instance, in case of perforation, it could come from wherever.
For example, right through this leaflet here. So when you image the aortic valve, keep this under consideration and scan the entire valve, and obviously, as with the mitral valve, use several views.
So not only color is important, we have to look at the morphology of the valve to understand the cause of the jet. And here, for instance, are a few examples. From these examples, we will learn about pathologies. So here, for instance, we have an aortic valve, which is
a little bit thickened here. You have a bit of fibrosis here and here and here. And does this patient have aortic regurgitation?
Well, actually, it's only traces of regurgitation, and this is a clear example of AR in aortic sclerosis.
And if you take a look at the next example, I think this is probably an even better example of aortic valve sclerosis, a patient who has massive LVH, again, a dialysis patient. I would say it's even a beginning form of aortic stenosis. Look at the stiffness of the valve here, and truly there is some degree of aortic regurgitation right here.
So actually you've learned that AR may be present in aortic valve sclerosis, usually is mild and hemodynamically insignificant. It comes with aging more often and rarely progresses.
What about this patient here? Do you remember this pathology we actually showed you in one of the previous chapters? Well, if you look at the valve in a short axis view, I think you will clearly understand what we're talking about. This is a bicuspid aortic valve. What does this mean? It means it has only two cusps, and very frequently will you find a dilated aortic root in such patients. You see the root is dilated, and not only that, but often there is some degree of prolapse of the valve. And if you look at the color Doppler study, you will appreciate that here we have aortic regurgitation. Now, this is such an example where it might be very, very difficult to detect AR because the jet is so eccentric. It's pointing here downward towards the anterior leaflet. You see that right here, and very difficult to see. Still, such forms of aortic regurgitation, as you will see later, can be quite significant.
Yes, so AR can be present in bicuspid valves. Actually, 70% of AR is present in bicuspid valves, often multiple jets, and they are eccentric, as the one we showed you, can progress and increases the risk of endocarditis. And here we have another example. Look at these extremely calcified and thickened aortic valve, which causes AR, but the flow is in acceleration also during systole. So we can guess this is a combined disease of the aortic valve, so regurgitation plus stenosis.
Wait, Anna, for a second. Let me just show you one other thing. Look at the ventricle here. Do you see how dilated the ventricle is? So we not only have aortic stenosis and regurgitation, but also poor left ventricular function. And I just want to mention that this patient also has a pleural effusion here. So you see, you can pick up a lot of things. So what do we need to summarize in patients who have aortic stenosis? Well, they also frequently have some degree of aortic regurgitation. And mostly the stenosis is the leading problem and not the AR, but it can be vice versa as well. And we have to understand that if we have two valvular lesions present in one valve, they influence each other, especially when it comes to quantification. This will play a role. For example, we will overestimate aortic stenosis in the presence of aortic regurgitation.
And here we have another example of aortic regurgitation, but this time we have massive AR. We cannot detect the reason. We have to look at the morphology of the valve, and when we move to 2D, actually we can suspect endocarditis. The valve is completely damaged. We see these structures moving in the LVOT tract.
Those are the vegetations here. And obviously this explains why the valve is so incompetent. It's disintegrated. Infection has ruined the valve. And this is another example, again, of aortic regurgitation in the setting of endocarditis. This time, regurgitation is maybe not as severe. You have a mobile structure right here. This is a vegetation, probably a little bit older, and the jet moves down from here to here. Difficult to quantify, but very important because this too changes the management of this patient.
So AR can be caused by endocarditis. Usually the jets are complex because we have valvular distraction. This is also responsible for acute AR, and it's a good reason to send the patient to surgery, especially if it's hemodynamically unstable.
Aortic regurgitation can also be caused if you have a problem of the aortic root. For example, here we have a dilated aortic root, and if that happens, the cusps of the aortic valve can kind of move to the side, and you will get a central defect in the aortic valve, and this causes regurgitation where we typically have a rather central jet. But there's another problem that can occur in the aortic root that can lead to aortic regurgitation. Here's an example.
Yes, and this is a really great example of aortic dissection. I say great because we can really detect the flap in the 2D image, and which is causing only mild AR in this case.
But AR can be very significant sometimes in dissection, especially if the membrane or the dissection goes all the way to the aortic valve, or sometimes you would even see the membrane prolapsing through the aortic valve. So this could cause severe aortic regurgitation. So in essence, all patients with dissection are candidates for looking at the aortic valve as well. So let's summarize. Other causes for aortic regurgitation are aortic dilatation and aortic dissection, which can occur in parallel or together. Now, in most patients, transthoracic echocardiography allows you to detect the reason for aortic regurgitation and also the severity. For example, in this case here, it's quite simple to see AR, but sometimes information is hidden, and sometimes you will need additional imaging modalities, for example, transesophageal echocardiography. And this is the same patient now. Look what happened in this patient. Well, he has a bicuspid valve, but not only that, but there seems to be a massive infiltration, a massive infection on the aortic valve. So what is the key message here is, in most cases, yes, transthoracic echo, but sometimes you also need a TE study.
And now that we know the causes, the possible causes of AR, it's important to assess the severity of the disease. And do you think it's difficult, easy to assess it?
Well, I think it's more difficult to assess AR than MR. One reason is that it's probably difficult to see the proximal portion of the jet because it's kind of behind the aortic valve. But if you get a lot of practice and see many examples, it will be easy. And especially if you take the recommendations that we gave you at the beginning of the chapter, for example, scrolling back and forth and playing the videos in slow motion. What we'll try to do here is we'll give you many, many examples and show you how we assess the severity just by looking at it from a visual perspective.
Here, for instance, are 4 examples. And my question to you is, can you say which AR represent a problem for the patient? So the biggest jet, the most significant jet.
Yeah, when you do so, look at how wide the jet is, look at the proximal portion of the jet, so the part that kind of is before the aortic valve or above the aortic valve actually. Now compare these 4 image loops. What do you think is the answer? Yes, I guess most of you got it right.
These 2 are the 2 cases with more significant AR. The jet is bright.
Yeah, we have a lot of proximal flow convergence zones. There's a lot of flow right here in the proximal portion. This is quite clear. Look, you can see the jet even in front of the aortic valve. You cannot see it here, and this patient actually doesn't have any AR at all. So this patient and this patient are those where you have to watch out. And in the next example, we'll show you the same thing, this time in a parasternal long axis view. The question will be, how would you grade these individual severities? And remember, we usually use a scale of mild, moderate, severe, where we also use intermediate stages like mild to moderate or moderate to severe. What do you think is the severity in these 4 cases? Okay, should we give them the answer, Anna?
Yeah.
Okay. Yeah. So this is how we would grade regurgitation.
Mild to moderate, the first case. Moderate is a case you already seen. And then the 2 most complex cases, which are actually
moderate to severe at least, yeah. So look again. The same holds true for the parasternal long axis view, you look at the proximal portions, very difficult to see, and you kind of compare how big is the jet in relationship to the LVOT. And definitely these two are the ones who are most severe. But again, this is very difficult to assess because it's a very eccentric jet. It might not appear a lot, but you can see that it's kind of eccentric and impinges here on the anterior leaflet. And if you ask me which of these jets has the biggest consequence for the patient, I think it's this one and this one here. They're moderate to severe. Good, so you saw some examples. I want to just come back to theory a little bit because I want to explain you again the different components of the jet. Now, in aortic regurgitation, the jet would obviously be from the aorta down into the left ventricle, and classically you would speak of a proximal part right here. So you would have what we call the proximal flow convergence zone, and here, this diameter here, where the aortic regurgitant jet goes through the valve, is called the vena contracta. And this vena contracta is probably one of the best ways of quantifying aortic regurgitation. We're not going to go into details here in this course because this is part of the master class, but just to briefly touch this topic, there are cutoff values that you can use to quantify aortic regurgitation. But Anna, do you think this is something that works in all patients?
Well, actually, I would use these parameters when I have the feeling AR is between mild and moderate or between moderate and severe. So the borderline cases.
Yes, that's why I would use it as well, and especially only if you have a jet which is easy to delineate, because remember what Anna said at the beginning of the chapter, the aortic valve is a complex structure and jets can come from all over the place, and sometimes you don't only have one jet but maybe several jets. So quantification is something which I personally perform a lot by using the visual assessment, only measurement in those patients where it's appropriate. And of course there are a number of different other features that you can look on in aortic regurgitation. We're again not going to go into details here in this course. The shape of the spectrum of aortic regurgitation plays a role, and also what we call the retrograde flow that comes from the aorta back into the left ventricle, which can be assessed by a view which is called the suprasternal view. We just want to show you this view because I think this method is a very important one, and even though it's something which is only more for the experienced user, I think at least you should have seen how it works. And as the name says, we're imaging from above the sternum. So we'll be imaging from right here, looking down towards the aorta. Why are we imaging the aorta from here? Well, I have to show you if I take away his lungs. So from up here, we'll be seeing the aorta. And we'll want to see how the flow is actually in the descending part of it and in the aortic arch.
Yes, the transducer, you have to remember, has to stay parallel to the vessel, and the marker will point up.
So this is about the orientation you have, because remember the ascending aorta goes to the right, and then it curves down and caudally to the left. So this is about the orientation you have to have. And if you look at the image that you get on your screen, you will get this.
Yes, and actually this is a really nice example of suprasternal view. We see part of the ascending aorta going into the arch with the branches departing, and the descending aorta. So the round structure in the middle is the right pulmonary artery, and when we move to color Doppler, we can see that we have an accelerating flow during systole, which is what the blood which goes antegrade. And what you have to focus on is the red flow which goes back into the arch, because this is the regurgitant jet. So it reflects also in the descending aorta.
Yes, and if you look at the pulsations of the aorta, they're very vigorous, which means that aortic regurgitation is probably severe. This is an indirect sign. Now, if you put the pulse wave Doppler somewhere right here, you will get a spectrum that looks like this.
And again, consider diastole. So you see most of this reversal flow happens during the early diastolic period, but stays high.
Well, Anna, I think we have to stop here because we're going into too many details that we actually want to show you in the masterclass. For you at this point, all you need to know is that probably the most important factor in quantifying aortic regurgitation is still the color Doppler, looking at it from a transthoracic approach, and your imaging qualities. Why? Because take a look at this example here. Does this patient have aortic regurgitation? Well, maybe a little bit. And see what happens if we move the transducer just slightly, a little bit to the right. And all of a sudden, this turns into this. So here, clearly, you can see aortic regurgitation. So at this point, I think it's very important that you learn how to image and that you practice as much as possible.
So from quantification to consequences. So what happens in presence of significant AR? Well, the left ventricle has to cope with a state of volume overload. This means it has to pump twice the regurgitant volume, and this brings to a dilated ventricle, which at the beginning is hyperdynamic and stays and cope with the situation. As you can see here, on the right, you have the regurgitant jet. On the left, you have the consequence. But then it can develop some kind of dysfunction until we reach states like this one that we showed you at the beginning. This is irreversible, this systolic dysfunction, and this means we have to operate and send the patient to surgery before. So consider always symptoms, severity of AR, and left ventricle size and function.
Yes, Anna, and it definitely shows how important echocardiography is in making the decision when to operate a patient. Now that we've answered your 3 questions, why does the patient have aortic regurgitation, how severe is AR, and what is the consequence, it's time for you to solve some cases together with us. Here is the first one. Now, take a look at these 2 images. Does the patient have aortic regurgitation?
Well, yes, at this point we can actually recognize the jet, which goes back into the left ventricle, and maybe from the 2-dimensional image we can also understand the mechanism behind it, because yes, we have this really enlarged ascending aorta, and maybe this is AR associated with dilated root.
Yeah, the jet is very central. We have a massively dilated aorta. Now let's take a look at the apical views. The next question will be, how severe is AR? Let's look at it again from the 5-chamber view. What do you think, Anna?
Well, this jet is not really small. We can detect the isoproximity velocity area.
Yes, the flow convergence zone, and it's quite large. So this is probably relevant aortic regurgitation, especially if you look at the size of the ventricle. It looks dilated. So there seems to be some degree of volume overload. And now we'll show you the retrograde flow. And
well, just by looking at the color Doppler, we see this huge amount of blood in red going back into the arch. And when we see the pulsed wave spectrum, we see this flow is during all diastole, so it's a significant AR.
Yes, and if we now look at the continuous wave Doppler signal across the aortic valve, what we see is that the patient not only has aortic regurgitation, but also flow acceleration through the valve, which means there is some degree of aortic stenosis. However, watch out, because with aortic regurgitation, as we mentioned previously, we probably overestimate the severity for AS. But to summarize this case, it probably is a reason why we should intervene, because the patient has severe aortic regurgitation, left ventricle function is probably already a little bit reduced, and we have an additional problem. We have the very dilated aortic root, and as you will find out in the chapter on aorta, this might also be a reason to operate him there.
And here is another case, a more complex one, where you can still detect AR. There's this really eccentric jet that maybe, as every eccentric jet, is underestimated in the presence of pleural effusion and a small amount of pericardial effusion. So let's see left ventricular function. Here is reduced, maybe more than in the previous case. So we have a patient with significant AR in the presence of heart failure maybe already.
Yes, this patient definitely needs surgery, and we can only hope that he will still benefit from surgery, given that his function is probably severely already reduced. Okay, so this concludes our chapter on aortic regurgitation, but...
Well, actually, there's something else we would like to show.
Yes, Anna, we forgot one very important topic, and this is acute severe aortic regurgitation, something which is relatively uncommon, but which certainly has consequences for the patient.
Yes, it's acute AR, as we are seeing here in this example.
With a massive regurgitant jet. And the difference to chronic AR is that in this case, the ventricle did not have time to adapt to this volume overload. And so the ventricle is still rather small. And, even relatively low amounts of aortic regurgitation can lead to massive symptoms, increase in filling pressures and dyspnea, and these patients can get into shock. Now, there are not so many causes of acute severe aortic regurgitation, but what we do know is that these patients frequently have endocarditis of the aortic valve, or frequently a rupture of a cusp, or some acute event that leads to such massive AR. And again, an example here, you see the parasternal long axis view in a patient with severe AR. Note that these patients frequently also have a very high heart rate. They have tachycardia because they try to cope this volume overload by increasing their heart rate.
So to sum up, acute AR is infrequent. It can be due to aortic cusp rupture, especially in the context of endocarditis. It can be also related to cardiovascular surgery, for instance, partial detachment of a prosthesis in aortic position, or can be due to aortic dissection.
Yes, Anna, this nicely summarizes acute AR, and it concludes our chapter on aortic regurgitation.